نبينا محمد على صحبه أجمعين. Today I will talk about the dysphonic patient and approach to the patient with dysphonia, a change of the voice. Okay. Hoarseness is a generic term used to describe many kinds of voice changes. It's frequently used to define a vocal quality that is rough or harsh. So hoarseness is a general term. You need to look for the from the history to look for the causes, and then you will manage your patient. How to approach for your patient? You will start from history taking. Now you have patient in front of you in the ER. He has dysphonia. So what you will do? You will start with a detailed history. The age of the patient. Is it young, old patient, infant? Lifestyle, smoking, coffee, fluids, and occupational habit and profession. If he is a teacher, singer, and other, okay, you look for his occupation as well because it can influence in his case. Now you have dysphonia. The onset of that, is it a gradual onset or acute onset? Duration, for how long now he has this problem? Is it a progressive? Any preceding upper respiratory tract infection, if he has a upper respiratory tract infection, later maybe he lead to laryngitis that can cause the problem for that. History of trauma, important, either direct or focal trauma. Focal trauma after shouting or after screaming, leading to that dysphonia. Direct either by trauma fall down or by car accident or any kind of a trauma. Or history of intubation, very important. While doing intubation, maybe they injury the larynx, so very important, like endotracheal intubation, one of the risk factor for other even benign lesion of the larynx. Gastroesophageal reflux disease, even without heartburn. Not necessarily the patient he will have heartburn, classic for gastroesophageal reflux disease. Maybe he will have globus, thick mucus, irritation on his throat, medical disease like hypothyroidism and other medical disease. You need to look for that because hypothyroidism may produce diffuse edema of the focal cord. History of surgery before, any head and neck surgery, thoracic surgery, look for that because any kind of surgery maybe lead to injury of the nerve, leading the patient he will have paralysis in one or even bilateral focal cord paralysis. And from the history, history of radiation, if he has any previous history of radiation, it can lead to problem in the voice of the patient later. Also other symptom, very important to look for other symptoms of the larynx, like uh, stride or noisy breathing for the patient. He has noisy breathing while he's taking breathing. He have that sound, noisy breathing, and also shocking spells. Any history of fever, sore throat, and other symptom, other ENT symptom, you need to look for that. Neck mass, look for the neck mass, neck swelling, and look all the possibility of the other causes of the change of voice. Causes, it can be congenital causes like laryngeal web, traumatic causes, inflammatory causes, acute laryngitis, granulomatous disease like TB, chemical by gastroesophageal reflux disease, which is an important part we are discuss later. Benign focal cord lesion like nodule, polyp, cyst, neurological causes, focal cord paralysis, thyroid surgery, mediastinal tumor or neuropathy, benign tumor like papillomatosis, chondroma, or either malignant tumors like squamous cell carcinoma lead to dysphonia. ENT dictum, any case patient he will present progressive, persistent dysphonia more than 2 weeks in a smoker should alert the clinician to the possibility of malignant disease, especially if he old smoker with progressive dysphonia. Think about malignancy until proven otherwise. If you have whitish like membrane here, mass, it can be malignancy. So you will need to look for that and approach to that patient. How we can do it? We will have it in the common head and neck tumor. Don't worry about that. So not necessarily only benign lesion, it can be malignant in change. So history very important, and occupational habits other important. After history, any question the history taking before going to the examination?
Clear, doctor.
Okay, we'll go to the examination. Again, complete head and neck examination. We like that to do every examination of the nose and even ear and throat, whatever. We like to do complete head and neck examination. You are focusing after that, you will focusing the complaint of the patient, like if he has complaining of the larynx. So we're doing complete head and neck examination, focusing on the laryngeal examination. We have subjective voice assessment. You will look voice quality, the pitch of the voice. You are hear the voice and see that is quality, pitch, loudness, duration, and rate of phonation, intonation, and range, and respiratory characteristic if he has other abnormality like with respiration, like sometimes the breathy voice, like because he has gap, so the respiration comes from down, leading to kind of that voice we will mention in the vocal cord paralysis. After that, you will do laryngoscope. So the specific examination of the larynx is laryngoscope, either by indirect by using the mirror or direct using the rigid or flexible scope. And we have objective voice assessment. The objective voice assessment, like voice handicap index, is a tool you are giving to the patient question. He will answer that question, is use a scale of 5. If it abnormal, if it more than 11 point, that's abnormal, like that here. This is voice handicap index, the name of the patient, the date. He will answer this question, like my voice makes it difficult for people to hear me. That's the scale, 0 till 4, so 5 scale. If it's 0, 1, 2, if it's 11, that means abnormal. So this patient has problem in his voice that leading to even social or problem in the patient, uh, either impairment or disability, handicaps, either socially or economic or environmental disadvantage. Okay, not necessary to know this question, just to understand we have the tool is objective tool. It's called voice handicap index. Now the important part of the lecture, but if you have any concern about the examination, any question in the examination?
Clear, doctor. One question only about the
Okay.
subjective assessment. How can I uh, assess the patient if I haven't heard his voice or her voice before?
You can assess either you will give the patient this like paper before he's enter your clinic, if he has any from the reception, if you know from his problem from the vital sign of the patient, if, between you and actually your staff, you can give the patient if any case of dysphonia, change of the voice, you can give the patient to look for that. Or after you're evaluating the patient subjectively, you can give him this tool, and he will answer this question and he will return it back, and you will actually see his problem from the beginning, from subjectively and objective, and better you assist your patient, After that, you will select the appropriate management for him. Is it clear, Abdullah?
Yes, doctor. Thank you.
So you can either before you're assessing from the beginning of dysphonia patient, but after most of the time is actually after you will give the patient, please you can go outside and answer this question and return it back, or in your clinic. It will not take like 2 minutes, 3 minutes. He can answer it very well. We have the benign focal cord lesion. We have nodule, which is the commonest one, is the nodule, polyp, cyst, rhinic edema because it affected the rhinic space, the superficial lamina propria, and granuloma, and then we will have the other normalities. So here only the benign focal cord lesion. So is not a tumor, is a lesion, first of all. Is a lesion, is not a tumor. We have benign tumor, but here we are dealing with benign lesion. So don't mix about the lesion or tumor, benign tumor or lesion. Okay, this is a lesion. The commonest one actually is the focal cord nodule, the most common cause of in children and even a professional voice user like a teacher. Even it's called singer nodule or teacher nodule. The other names of the focal cord nodule is a singer nodule or teacher nodule because most of the time is appear on this occupation, in this professional. You will see, how can I see? This is the focal cord. This is the right focal cord. Why the right? Because here we have, this is the anterior commissure area. Most likely the epiglottis is here. So this is the right focal cord lesion, and also it's the left. So it's well defined focal cord lesion, small.
دكتور
البوينتر انا ما اخذه ولا في واحد كان اوله؟ طيب البوينتر اوكي sorry because I saw other pointer before I thought that my pointer. Okay, this is the right focal cord. This is the left focal cord. Why I know that? Because here posterior it has a gap. Here it's narrow. Even this is the area's anterior commissure area. So we have lesion in the anterior two-third at the junction of the anterior two-third and posterior two-third of the focal cord. So most likely the area of the focal cord nodule. Why? Because this is the maximum vibration area, the maximum contact area, because it's contact very close together here, leading to the inflammation here, leading to small inflammation, lead to the form of the focal cord nodule. It will be whitish, are generally bilateral at the junction of the anterior one-third and posterior two-third. So at the junction of anterior one-third and posterior two-third. Here, what is it? Is it right or left focal cord? What do you think?
رايت
Right.
رايت
Yes. Very nice. Right. Is it left or right? No one left? Okay, that means you understand very well from the lecture. Here you have even the epiglottis, and here you the right. It will be angle here. This is anterior commissure, so this is you are looking for the patient from here. So this is the right and left focal cord. Treatment of the focal cord nodule, mainly actually by the voice therapy. Patient is taught to how he's using his voice appropriately when often promote regression of the focal cord. So we are giving the patient voice therapy, or other is called speech therapy. Uh, they have speech pathology in actually in the hospital. You will send the patient there. They will ask him and they will inform him how to use his voice in a proper way and to avoid the trauma to the focal cord. If that failed, rarely you are doing the surgery like microlaryngeal surgery with or without whatever laser, or I will not ask about, but microlaryngeal surgery. I like to just know that the name of that surgery is microlaryngeal surgery. Okay, so the surgical option on the focal cord nodule is microlaryngeal surgery. In general speaking, General management of the focal cord lesion is speech therapy and microlaryngeal surgery, and medical, if you want to add medical, anti-reflex medication. Why anti-reflex? Because they found that maybe reflex can lead to inflammation of the larynx. So to avoid that, any kind of inflammation, and to eliminate any factor that causing abnormal to the larynx, and you will give them, but mainly the speech therapy or voice therapy and microlaryngeal surgery. You can apply it in the focal cord polyp, and also the granuloma and other any kind of focal cord lesion. It has some difference on that. If it related to smoking, so we will stop smoking, ask him to stop smoking, and the management is the similar management. So the surgical management of that, it's called microlaryngeal surgery. We'll not go in detail on that. So you'll remove that cyst, okay? Any question, Danidule, before going to the focal cord polyps?
Clear, doctor.
Okay. Focal cord polyp. Now we are doing history of voice abuse and heavy smoker. So the risk factor of the lesion, of the focal cord lesion, we have voice abuse, one of the risk factor. The other risk factor is smoking. The other risk factor is the reflux. So we have risk factor leading to the benign lesion. Here we are dealing with a smoker. So smoker is a risk factor focal cord polyps. Laryngoscope often pedunculated unilateral lesion, not like the focal cord nodule. Focal cord nodule is usually bilateral. It's a start from one side, but because the contact to other side leading to inflammation to other side, then it lead to bilateral, and the patient he will have that kind of dysphonia. While here in only one unilateral, similar to laryngeal epithelium, like not like whitish on the that area for the focal cord nodule. Here it's similar to the focal cord, to the mucosa of the focal cord, similar like that. Treatment, so it's a big. Now we are dealing speech therapy is often not successful, but although you can send the patient to voice therapy, but microlaryngeal surgery using instrument whatever, and to excise that polyp. So the management is the same like vocal cord nodule, but the priority is different. So not you will start voice therapy, maybe you will have microlaryngeal using surgery. And even after any kind of laryngeal lesion removal, you need to patient, you will have like for speech therapy, post-op speech therapy, and also voice rest to avoid any contact trauma and return of that lesion. Rhinic edema, now the polyp, not like this is their accumulation of the fluid in the superficial layer of the lamina propria. Here you can see there is accumulation of fluid. It will be bilateral. The focal fold, it will be boggy and can be rolled beneath the instrument. So you can see that you can roll out that because it's accumulation of fluid. It can go anywhere. Treatment. Now we are dealing with smoking cessation. So it's the key to resolving is smoking. So it's one of the risk factors for rhinic edema is smoking. So one of the management of that is smoking cessation, speech therapy, and microlaryngeal surgery. I will not go how to, what we will do usually what we are doing, but to know and understand the name of the surgery, it's that important. So it's not only one lesion, small lesion, or one lesion bilateral. It's bilateral and accumulation of that, and the treatment is cessation of smoking, speech therapy, and microlaryngeal surgery. Any question on rhinic edema and focal cord polyp?
Just rhinic edema, doctor. What's the اللي هو clinical presentation of it?
Change of voice. He will have change of voice. If it more obstructed, lead to the noise, to the breathing problem. So he has a kind of respiratory, any kind of respiratory distress.
clear,
Okay.
doctor. Thank you.
Don't think about only the dysphonia, other symptom like respiratory distress, because dysphonia, he will not die from the dysphonia, but he has any kind of respiratory distress symptom, severe symptom of respiratory distress, he will have the problem. Unfortunately, we don't have the stridor, but you will one group they will have it on the seminar. But Strider is very important if everyone just to go back and to look for what we the definition of Strider, how we can approach the Strider for the patient. Maybe at the end of the lecture after they finish, maybe if you have any question, I will look for that because very important. If the patient he has mild symptom respiratory distress, the approach for the patient is not like severe respiratory distress. If he has severe respiratory distress, the priority is the airway, to secure the airway, either by intubation or tracheostomy. So very important, while you evaluate your patient, any kind of dysphonia, look for other symptoms. Respiratory, is he in distress or no? If he in distress, not necessarily you are taking detailed history, maybe the patient he will collapse in front of you. So the important, if he has any kind of respiratory distress, like increase his respiration effort, cyanosis, using his accessory muscle, he was tachycardia, now he coming bradycardia, oxygen saturation now below 90. The patient, his level of consciousness is not alert. So very important while evaluating for the patient. Okay. في واحد one is using the pointer, please don't use the pointer. Okay. Here
دكتور
the
تقدر
yes.
تقفلها. تقدر تعطيه مودريتر وقفلها عشان خلاص بس انت اللي تستخدمها.
Okay, no problem. خلاص, he will just stop, he will not use it for sure, he will not play in that. Okay. Laryngeal cyst,
اوكي دكتور.
laryngeal cyst, either mucus retention or epidermoid cyst. Okay, this is the cyst, either mucus inside here or epidermoid cyst, like a nodule, but usually unilateral. But speech therapy will fail to resolve the nodule. Here is not like speech therapy, the laryngeal cyst, he will not go by speech therapy. So the treatment is microlaryngeal surgery. You will remove that cyst and with whatever your instrument. But even though you will add him for speech therapy, so the management also include the speech therapy and microlaryngeal surgery. So it's not the junction of one anterior and two posterior, not bilateral. Is it on the right or left focal cord, the cyst?
in the left.
Okay, very nice. That means you are understand. Because maybe we'll ask you later in the OSCE or something, is it right or left? Oh, so very important to know that even the lesion of the patient, if it's not one is mobile, is it right or left? Is it has difference in management and evaluation for your patient. Okay, focal cord granuloma. It can be unilateral or bilateral. Focal process granuloma, because it's attached to the focal process of arytenoid cartilage. Here the arytenoid, which attached to the, this is the focal process of arytenoid, because the focal ligament is attached to the focal process. So if you have lesion posterior at the focal process, this is a focal process granuloma, okay? Not anterior, not at the middle, not posterior, posterior in the focal cord, at the junction of the focal cord. This is the granuloma. The risk factor for that, gastroesophageal reflex. Now we are dealing with intubation. So any history of intubation or traumatic intubation is a risk factor to develop granuloma. So patient after surgery, intubated. After that, he start to have tumor. You find the lesion on the posterior of the larynx. Most likely you are dealing with the granuloma. Okay, it can be dysphonia, odonophagia, cough, and globus symptoms. Stroboscopic examination show collagen of the cartilage leading to that area. How we can treat this patient? Voice therapy, microlaryngeal surgery. Now we are adding like Botox injection. You will put Botox injection to paralyze that area to avoid the contact, and this the patient medically you will start him anti-reflex medication and to look for the patient, and it will be resolved most of the time. If not resolved, you will remove it by microlaryngeal surgery. But here you have the treatment option for that. Any question? The focal process, granuloma or focal granuloma or cyst?
Clear, doctor. Thank you.
Clear.
Okay. Thank you, everyone. Now we have reflex laryngitis. Patient who will have chronic hoarseness, chronic cough. So look for the patient. He has change of the voice, chronic cough, frequent clearing of his throat. He's try to clear from the mucus, the sputum, shocking, globus sensation. He are feeling something inside his larynx, or cervical dysphagia, pain in the, or bad taste in the morning, excess phlegm, mucus. I mean excessive mucus. Heartburn may be absent, so it's not necessarily the patient he will have heartburn. That means patient you will label as reflux laryngitis. So it has more symptoms: chronic, annoying cough, frequent clearing. It have even index and other. I will not go in detail on that. But how we can know pathological to know the endoscopic picture? If you are looking, you have posterior laryngeal inflammation. You have inflammation in the posterior of larynx. Why? Because in the posterior we have the esophageal inlet leading to laryngeal contact ulcer. It can lead to laryngeal granuloma formation. Also here granulation formation on the focal process if it goes deep, that reflex, because the reflex is more sensitive, the larynx is more sensitive to the acid. So if you have any reflex, it will inflame and causing problem. Other like laryngeal tracheal stenosis or laryngeal carcinoma, it can lead even to laryngeal carcinoma, or the risk factor of laryngeal carcinoma, or stenosis of larynx. It can affect of that. Okay. We finished the benign lesion. Now we will have the benign tumor, like papillomatosis. Papillomatosis is by human papilloma virus 6 and 11. It will be multiple, irregular warty growth. So if you have irregular warty growth, multiple, patient he will have dysphonia. Also he has stridor, noisy breathing, and cough and other symptoms. Treatment for that, because the tumor will not go by medical or speech therapy, so you will do surgery like microlaryngeal surgery and excision of that. Most of the time it's child, unfortunately. It's preserve the structure and function of the focal cord, the aim of the surgery. And in such case, avoid doing trichostomy. If you are looking scope, looking for irregular warty growth, if he has patient, he has respiratory distress, and you need to stabilize the airway, try not select the trichostomy. Why? To not separate that lesion, that tumor. Because if you doing that, maybe you're going to the down to the trachea. Now it's larynx. It goes to the down to the trachea, needing to more inflammation. Imagine that this tumor it regrowth again, because it will, if you remove it surgical, you will do only surgical debulking. It will return back. Some cases actually it will return. You will have 4 surgery per year. You will admit 4 times to do surgical debulking. And we have other management, not only the surgical or microlaryngeal surgery. We have adjuvant therapy like a cyclophyr and other medical or treatment. You can use it for the patient. I will not go in detail on that. Okay. Any question B9 بابلوماتوسس؟
الدكتور
Yes.
الدكتور أنت تقول إنه ممكن يسوي يعني 4 مرات بالسنة
Yes.
السر يعني
Yeah.
بشكل عام
Regrowth.
إيه أقصد هل بشكل عام هل ممكن الشخص كذا طبيعي بيسوي 4 عمليات يعني بالسنة أو
Yeah. If it causing respiratory distress and causing airway obstruction, it can lead to that. You can admit the patient and do it. If you every time, because regrowth, it can regrowth and closing the airway. Here is fine, the airway, yes. But if it like that, imagine that pediatric is small airway. So even 1 millimeter in the pediatric is make different. The narrowing 1 millimeter, it will obstruct 60% of the airway. So imagine if the narrowing is more than 60%, how we can lead that patient? He will have respiratory distress. So the aim of the patient, you will have it. It's not necessary all the patient, but 4 times per year, but it can 2, 1, 3, whatever, according to the regrowth and for the patient and your management as well. Is it clear for your answer?
Yes دكتور جزاك الله.
So any causing of respiratory distress, okay, the priority, you will aim for that because it will keep growth. So now he has a problem. So we need to solve that problem either by surgery. If it's option, you will do it. Now we will have the cancer larynx. We will discuss detail on the tumors, but to know if you have patient glottic cancer give early change of voice because the focal cord, if it at the focal cord leading to the narrowing contact that leading to the change of voice, maybe you will diagnose the glottic cancer early rather than the supraglottic and subglottic. Unfortunately, supraglottic and glottic, it will be late manifestation. But glottic, it can be present early and it can be like whitish irregular mass with abnormal vascularity, whitish mass or abnormal vascularity or ulcerative mass, can do fixation of the larynx, that fixation of the focal cord, the mobility is restricted, immobile focal cord. Diagnosis طبعا like any microscopic examination and biopsy. Treatment according to the management of the according to the staging. We will have it on the common and head and neck tumor. Don't worry about that, but it's staging your patient and either early stage or late stage, and according to that you select single modality, double modality. I will discuss in detail with you. I will be with you in the common head and neck tumor. Don't worry on that, okay? Now we will go to the focal hygiene. After the focal cord, you will voice education, no shouting, no loud laughing, yelling, no spicy food, and other will voice rest, mucolytic. Very important, give the patient steam inhalation to lubricant the airway after the surgery, anti-reflex treatment. Also, other way you will tell the patient other way of communication because voice rest by writing or by other. Now we will have the focal cord paralysis. We have unilateral recurrent laryngeal nerve paralysis or bilateral recurrent laryngeal nerve paralysis. Unilateral, that only one focal cord is paralysis. Bilateral, both focal cord is paralysis. The causes is either iatrogenic, that means during the surgery, after the surgery, whatever, head and neck surgery like thyroid surgery, the also chest surgery, thoracic surgery, primary and secondary lung carcinoma. So any lung cancer can lead to paralysis because the course of the recurrent laryngeal is down, malignant tumor of esophagus and thyroid, aneurysm of the aorta or left arterial dilation aneurysm, trauma it can lead, or it can, if you don't have any cause, you can label the patient by exclusion the idiopathic. So if you have no clear cause, you look for the patient, doing examination, doing investigation, CT, MRI, and everything. Still, you don't have why the cause of that focal cord paralysis. This patient, you can label the patient he has idiopathic focal cord paralysis. Symptoms: the patient he will have breathy voice. Why breathy voice? Because the focal cord will not close, so leading to the escape of that air. When he is taking, he will speech, he will have that also breathing come from that speech. This is called breathy voice. Maybe tired with use. Sign: it will be paramedian focal cord paralysis. This is a median. He will be paramedian focal cord paralysis. Lesion below the origin of the superior laryngeal nerve. Whatever the lesion, it can be also other focal cord maybe compensate for the mobile one, degree of hoarseness experienced. So maybe he will have mobility, but he has some change of voice, but you will look for the patient, he has paralysis. But the other focal cord actually is compensate with that. Move to close the focal cord. Try to compensate and leading to look for that. See here, if he has left focal cord, but the right is actually is moving. Right is moving here, okay? So is more common, so the left is more common than the right focal cord. Why? Long course. Here you have the patient mobility. The arytenoid is actually moved toward the midline, but the other is not moved because the focal cord is not moved here, paralysis, leading to that he has left focal cord paralysis. Imaging studies. Patient now present with a focal cord paralysis. You scope the patient, you look for he has paralysis. What next step you will do? Imaging studies, okay? You will do either neck, chest x-ray, chest x-ray, neck, chest x-ray, it's okay. Or CT scan. CT scan, neck and chest, whatever you will select, to look for the possibility of the cause. If all the actually imaging studies is negative, then you need to do that bronchoscopy, endoscopy bronchoscopy should be considered to look for down, to look what are be the causes for that, okay? Now patient he has idiopathic treatment, not a cancer, okay, not clear cause for that. We have non-surgical and surgical management. It's called expectant treatment. So we are expect the patient to wait till the patient he will resolve. Is recommended when there is no underlying malignant growth. Most unilateral cord palsy compensate within 6 to 18 months. It can compensate, okay? Patient age, occupation, and preference as should be treated, should all influence the treatment plan. So patient he will have now, will do for him expectant treatment till resolve. Patient he will not have any kind of yes. Is it the sound clear for everyone?
اي نعم دكتور واضح.
Yes.
واضح دكتور.
Okay, very important because the sound is come down. So the treatment of unilateral focal cord idiopathic is expectant treatment. The other treatment, this is non-surgical. The other treatment is surgical treatment. We have two important surgical treatment: injection laryngoplasty. The aim of that, we will medullarize the focal cord. So because it's paramedian, we try to be medullized, okay? By doing injection laryngoplasty, we will inject here to medullize the focal cord. Or other is called medialization thyroplasty. So we need to memorize the surgical measurement for that. We not mix between the bilateral, because here medialization thyroplasty. Okay, because the important to medialize for that. I will not go in detail how we can do it and that. Any question on the unilateral focal cord paralysis? So in general management, patient approach, you scope the patient, he will have focal cord paralysis. Next step, after complete examination, I will select the investigation, either chest X-ray or CT scan or whatever other other also. If it pediatric, maybe will look for, you will ask about MRI brain if it bilateral focal cord paralysis. But in general, if unilateral, you will ask about CT scan and look for the cause. Still negative, you will do bronchoscope, endoscope to look for the lesion from inside. If it idiopathic, or you will, how you manage your patient, either by non-surgical, by expected management. So I will manage the patient, give him follow the patient 6 to 18 months, maybe he will resolve. Unless he need to his voice, I need to enter, I will do surgical management like injection. If it failed, that not after 18 months, I will goes to the surgical measures, either injection laryngoplasty. So I will do medialization procedure, either injection laryngoplasty or medialization thyroplasty. Bilateral focal cord paralysis. So now we have bilateral recurrent laryngeal nerve paralysis. So if it's bilateral, that means affect the posterior cricoarytenoid. The patient, he will have respiratory distress, not only the dysphonia. So the management even now change. If it's bilateral, maybe you will lead, if he has respiratory distress, need to look for it. Rarely as advanced malignant thyroid tumor may be underlying cause. Usually after the acute total thyroidectomy, patient after doing the surgery, after in the recovery room, he will have stridor, respiratory dysphonia, respiratory distress. Think about that, it has bilateral focal cord paralysis. Sometimes very rare, but presentation may be late as normal voice production, because according to the position of the focal cord. If it not on if it paralysis not in the midline, leading to the not leading to respiratory distress. In the midline, to narrowing the airway, if it like that, will be narrowing the airway, patient will happen. But sometimes bilateral focal cord paralysis not in the midline. They have space, they have air coming down, because possible voice production can be the normal voice production, because why? That lead to the, it will close normally, because it has paralysis, and it has some spaces leading to the normal voice. That's very rare in that. Clinically, often present as airway emergency, not like unilateral focal cord like dysphonia, airway emergency. Airway after an upper tract infection, sometimes decompensation, because the focal fold are adductor. Minimal swelling may be the stridor effect. How we can treat this patient? Now, the tracheostomy is one of the management of respiratory distress. Tracheostomy, that means we are opening the trachea and insert the tube. It's called tracheostomy tube. This is tracheostomy tube. Why? We will make the airway here, the tubes, and connect it to ventilator, or even he can breathe through that tracheostomy tube. Some patients choose to be kept their tracheostomy tube rather than to do any kind of surgery on that. They can live with bilateral focal cord paralysis. But the other management surgical measures, now we have lateralization procedure. So it's called lateralization procedure, like what is lateralization thyroplasty. Other name is either by stitch lateralization, doing stitch suturing lateralization, or arytenoid procedure. Arytenoid, that means where the arytenoid we will either partial arytenoidectomy or complete arytenoidectomy, removing arytenoid to give space for the airway. So surgical like lateralization procedure. So we need to lateralize, not medialization in the unilateral lateralization to give airway for the patient. Okay. This is the microlaryngeal surgery, what we are doing in the surgery. We will connect the laryngoscope here. This is the laryngoscope and connect it to microscope. So microlaryngeal surgery. So we are using the microscope because you need to magnify the airway and to look for the lesion and to remove it in proper way. Any question on the focal cord paralysis?
دكتور
تفضل. Yes.
باللاتراليزيشن اللي قبل شوي السلايد اللي راحت، ليش نسوي لاتراليزيشن؟ مو باسهل يعني لو مثلا واحد من الفوكال كورد يصير له يعني قطع يعني؟
This is bilateral focal cord paralysis. So if you do bilateral, you will do lateralization. You mean one or two focal cord?
اقصد مو في طريقه اسهل من اللاتراليزيشن، مثلا لو مثلا يسوي عمليه مثلا فوكلكتومي يعني يقطع جزء بدل ما يسوي يعني
Like
أحسن.
arytenoid procedure, arytenoidectomy. Yes, this is the procedure.
هذا هو.
But according to the preference of the patient, this is if you only stitching. When you remove the stitching, it's okay. You will not remove any part. But arytenoid, that means you will remove part, leading to later kind of aspiration and other problem. Okay.
تمام.
So this is according to your consent with your patient and the complication of that procedure. Every procedure it has complication. Okay. And what you prefer for the patient, you'll discuss the patient in front of him about the option according to the patient and the case itself. You will inform him that it will be better to do a arytenoid procedure, but the complication of that maybe later you will remove one part of the arytenoid, so later you will have like a kind of aspiration and other.
تمام شكرا.
Yeah. So any case, any surgery, it has indication and complication. So when I select that, is it this procedure indicated in this patient or no? According to the age of the patient, according to the disease itself, manifestation for that. So it has indication and complication. Any question?
دكتور
Yes.
بعض الناس تجيهم بدون حرارة بدون شيء، يعني مو بشينجينج اوف فويس، ابسنس اوف فويس، يقعد 3 ايام او 4 ايام، يصير يعني اذا تنحنح شوي تعدل صوته، بس على طول كلمتين بعدين يصير ما يقدر يتكلم نهائيا بدون ألم وبدون شيء. هذه وش هي؟
This is most likely he has some sort of laryngitis, and they have type of laryngitis, inflammation of larynx.
تمام.
Okay, but you need to you will approach your patient like dysphonia, like you are approaching this patient. Detailed history very important. Examination, and you will scope the patient, direct laryngoscope to look for the lesion. Most of the time you will find inflammation. You will give the patient, if he has infection, you will treat the infection. If it's small, just viral, you will give him analgesic, instruction, voice therapy, uh, other manifestation like anti-reflex medical. Otherwise, if he need any kind of other management, you will give him your better management. But he need to approach to look for the diagnosis. According to the diagnosis, you will manage your patient.
تمام، الله يعطيك العافية.
دكتور.
Yes.
ENT dictum ايش معناه يعني بالضبط؟ اللي اخذنا
That mean like statement, very important statement. يعني قول مأثور، يعني شيء متعارف عليه. اوكي.
دكتور.
Yes.
هل في ادفانتج ان نسوي ريتينويد بروسيجر اوفر ليتراليزيشن؟
Yes, we have advantage. This is the indication and complication. and also the for successful rate for that and that. I will not go in details in that. Okay, but they have advantage. Every procedure they have advantage and disadvantage according to you and your what you prefer for you and according to the patient and what will be the cause for that. You could select the patient proper way.
Okay, thank you.
You're welcome. Any question?
جزاك الله خير يا دكتور.
يعطيك العافيه دكتور.
Okay,
دكتور في
thank you
سؤال.
for your